So you heard longevity. How long does fat last? Does it last a day, or does it last 3 months? Does it last a year? It's permanent. If the fat takes, it's permanent. My mom is over 4 years out, and she looks just as good, if not better actually, in some respects than she did even a couple years ago. But how long does it last? Why, when I was studying for my hair boards, I started to really understand that fat is a graft. So why would it walk up and leave at 3 years? Would you have a skin graft you put on the arm, all of a sudden just disappear in 3 years? People say, oh, fat lasts 2 years. How do you say that? The fat is either going to die or it's going to live. There is no other in between the two. It's a graft. This is not Restylane. It has blood supply or not. So when I started to understand how hair developed over time, you would see hair go through different processes of a free graft. And over a period of about 6 months to a year, the graft would start to neovascularize, have new blood supply. And I would see these patients a year to two. I had one lady from Taiwan, I didn't see her for like a year and a half, at 2 years, didn't gain weight. I asked her exact same weight. She just looked 10 times better. And there's a vascularization of the graft. Not everyone gets this. Sometimes the fat is not perfect in its take, but in general, you can see improvement. So what I see is gross swelling, and sometimes at a month, it's almost artificially good because it stretches every wrinkle and pore out. And then it goes through a period of time, somewhere between 3 months to 9 months, where it may not look as good. And that's when a lot of doctors give up. They go, oh, it didn't work. I saw him at 3 months. It's a joke. Well, do you look at your rhinoplasty results at 3 months and go, that's the end of it? No. Do you look at your facelift results at 3 months and say, that's the end of it? No. Well, why should you do that with fat? Because fat is going through a quiescent period where it starts to revascularize and starts to vascularize and get better. Minus further aging, you know that glass of water analogy where it starts to go down, you have to look at your long-term photos. So I encourage you, for all your patients, just like with your rhinoplasty patients, you're taking those photos, take the photos of your fat and watch them over time. If you don't do that, you don't have feedback to understand how much fat to put in to get what kind of results. With the question of PRP, do I do that? No, because I get generally good take. And if I add any more, I think the fat will be too much. You don't want a fat face, you want a face that looks elegant. So let's go through a year or a year and a half with the lady with, again, the only thing I did was neurotoxin for her, nothing else. And if you look at her about a week, it's puffy, it's bruised, it's swollen, it's not quite good. And then at about, a month out, still a little full and looks good. And then about 3 months, maybe that looks better, maybe it doesn't look as good, doesn't matter. It's just about, a change in the face that's going down. 6 months, maybe it's gone down more. Maybe you're thinking it's going to disappear now, so it's going to be a trajectory going toward loss. And I've got many of these photos on my website if you want to look at them. 11 months, it's starting to improve. And at 15 months, you can see she has a softer look to her, now 50 versus 48. And the only thing else I did was Botox for her, nothing else, and very standardized all the way through. So donor dominance, this is the concept extrapolating from hair. People that do hair restoration understand this, which means if I take hair from the donor area and move it to the front, it will behave like the hair on the back of the head. Well, that's the same thing with fat. So what is the biggest risk with fat? Is it lumps and bumps around the eyes? I don't believe so. If you're doing controlled work, careful work, not over excessive work, you're going to get consistently reliable, good results. What is the fear that I have, that I convey to my patients before I start? It's weight gain. If you think about the donor characteristics of fat taken from the belly and thighs, it's very prone to weight gain, and it's very resistant to weight loss. I've had patients lose 10, 15 pounds, and they still look pretty good. My mom's lost 15 pounds since her procedure, still looks to me excellent. But when people start gaining 20 or 30 pounds, there's more risk. So I always want to remember that and be careful when you're dealing with people at a very young age and you're trying to place fat into someone 20 before metabolic changes, before pregnancy. You want to be a little bit more careful when you're doing this. Fat is not Restylane, it is a graft. So again, if you're doing careful work, what I'm not worried about so much is lumps and bumps. What I'm worried about is patient compliance toward weight maintenance, and especially in Texas. That's where obesity is the king. So you heard me mention briefly, like with hair restoration, I am using PRP. I'm doing my first case in a week from now because I've seen the studies. I think that early PRP, maybe mixed with A-cell and other things out there, could potentially increase growth. I want more hair than I can get. You're not going to complain I put too little hair up here. You're not going to complain I put too much hair up here. You're going to complain I put too little hair up here. Whereas with fat, it's not the case. You put too much fat in, it's not necessarily good. So I don't think I want any better take than I have right now. At least that's my opinion. You can ask 10 people, you get 10 different opinions. Implants versus fat. When do you use an implant? You've heard some really good talks about implants this morning. What is my philosophy? I really believe like for like, replacing like for like. What does that mean? So remember, to me, I think the principal mechanism of aging is fat loss over time. You do lose some bone, but I think with good dentition nowadays, it's not a major component as soft tissue loss. So there's a disproportionate amount of soft tissue loss compared to hard tissue loss as we age. And if that's the case, we're going to start exposing hard tissue below. And what we don't want to do is put an implant in and exacerbate that relationship where you're actually getting more exposure of underlying hard architecture. So what would be more ideal perhaps is to go back and increase that using fat transfers so that you actually soften the transitions and increase the padding and the soft tissue envelope. This is a good example of bone exposure we started with. So what I believe is with implants, I think you expose transitions. Obviously done some certain implants you're okay with, and with fat grafting I think you decrease it. That's it. Thank you for your attention. That's my email if you need to reach me. Okay.